Hello, everyone, and welcome to the slightly delayed start due to some IT issues we've been having to the Health and Wellbeing Board. So everybody should have sight. Does everybody have sight of the agenda and the timings in front of them? I know we haven't managed, not everyone's able to get them online. Okay, so we have received the following apologies. So Zoe Campbell from Tuve has sent apologies. And I believe David Kerr is attending in her place. Tracy's just gone down to see if they are here. Tim Forber from North Yorkshire Police has sent apologies, and Fiona Wiley is here as a substitute. And Simon Morritt from the hospital has sent apologies, and Lucy Brown is here to substitute. And we also have apologies from Councillor Mason. Does anybody have any declarations of interest they wish to make before the meeting? No. Okay. So has everyone managed to see the minutes from last time and happy to sign them off? I think I just had one issue from last time, and I will discuss with David when he comes back up, but that was just to discuss whether the public speaker had any follow-up or managed to speak to people around their care. Sian?
I also wanted to just follow up on that. I understand we misgendered Lely, who uses they, them pronouns.
Okay, thank you. Thank you.
I just had a point of accuracy on page 9. It said the National Trust are closing their doors. I hate to spread that rumour. It's grant making trusts in the hundreds are closing their doors. But not the National Trust.
Thank you. Okay, so in public participation, we've got one person who's registered to speak, and that is Jonathan Beatson. And he is going to speak under the general remit of the Health and Wellbeing Board on experiences of mental health services in York, and drawing attention to the importance of good mental health services. Jonathan, would you like to come to the table? Thank you. And you've got 3 minutes. Would you like me to give you a 30-second warning when you come in towards the end? Okay. All right, whenever you're ready then, thank you.
Thank you, City York Council, for making for me to come down and speak to you. Mental health is so important to people. We've got not enough services in York. The only service I know is the Haven, which is at 30 Clarence Street. They're operating 6 till 10 and 2 till 10 on the weekend. Without that service, we don't have enough support. Sadly, people taking their lives. And I'll go into a little bit of background of mine. I was at York College and I had a CAMHS assessment. They said I didn't need the help. I started with mental health. And then they decided the crisis team need to be interventions. And they intervened and got me the help. Now, there's a lot of failures with mental health these days. It's upsetting people for the loved ones, especially coming up to the Christmas period where they feel alone, they can't come out and talk, mostly men. I couldn't talk to begin with, and then I got the help and I could come out. It's dark, it's gloomy nights. This is an important time to see if we can really act on mental health, because without it, it's going to be catastrophic. It's going to be catastrophic. The police work hard on mental health, but they're not trained on mental health as such. They've got the streets triage. They're everywhere short-staffed. We need a hub. We need people that they can trust to go in and sit down and talk to, where they can easily signpost people. I'm literally shocked of what the government's done. It's broken the NHS, and the crisis team are understaffed. We need more staffing.
You've got 30 seconds.
Thank you. We need more staffing for this, because at the end of the day, we want to save people, not let them down and not let them be a failure, because that's what it's doing. So I'm asking you guys tonight, what can you do? Because coming up to Christmas period, coming to dark nights, you know, they're going to be alone, no one to talk to. That's going to trouble them.
Thank you very much, and thank you for coming to speak here. We really appreciate it. We really would like to talk to you more about the plans for the new mental health hubs coming forwards and the plans that are going around that. Be really happy to speak to you after the meeting or at another time. Okay.
I'll leave my contact
Yeah,
number,
please.
and someone can get in touch with me, and then I can come back in and we can arrange a meeting to see what we can do.
Okay, thank you. Ben says he's got your number too that he can pass on to us, but thank you. Thank you. Okay, and there's one more thing under public participation. Councillor Waters has made a written submission to this agenda, and there should be a printed copy for every board member on they should be around. I hope everyone can see one. And he raises concerns around the effectiveness of the hospital and GP services, as well as capacity in the system for an increasing population. So just to note that the health and wellbeing's role is to assess local needs, health needs, through the Joint Strategic Needs Assessment, sometimes called the JSNA, and this sets out how they will be addressed through the local health and wellbeing strategy and promote greater integration and partnership working. Some of the issues that Councillor Waters has raised have recently been discussed at the Health and Wellbeing Board, including access to GPs, and we do have a standing item of updates from the Health and Care Partnership, sometimes also called the Place Partnership. And the Place Partnership does have a substantial body of work underway around integration and joint commissioning. And we have also had a recent paper at Health Scrutiny regarding the urgent care services. So I have provided Councillor Waters with a written response, and I also believe that we should be looking at referring these to the Health and Housing and Adult Social Care Scrutiny Committee. Thank you. Okay, just to note on the agenda now, we're going to be doing it in a slightly different order, just for people's availability, but we will still be covering all of the aspects. So the next item we're going to look at is agenda item 6, and that is the update on goal 10 of the local health and wellbeing strategy. So I'd like to welcome Joe McKayley and Penny Hutchinson, local area coordinator, and Peter Roderick will also be presenting within this. We have 30 minutes for this item, and that's for the presentation and the discussion. Thank you.
Thanks, Chair. I'll kick us off if that's okay. Massive thanks to Penny and Joe for joining us today. So the board will sort of remember that we have a health and wellbeing strategy, which is our overarching way of looking at the whole population health in the city and improving it. As part of that, we said that there were 10 goals, and they were really quite measurable goals, things that we wanted to change based on the needs assessments that we do in public health. So things like people's physical activity, diagnosing diseases early, and then we get to this goal today, goal 10, which is around reducing the proportion of adults and young people in the population who report feeling lonely. So we've got to goal 10. We've been through all of the goals, and by the time we get to the next Health and Wellbeing Board, I think as a group we'll be considering what we want to do next. We'll be 2 years into this strategy, and I think there's something about, you know, how we continue to monitor these goals and continue to make sure we're making the progress. As part of the goals we set, I think 26, 29, something like that, actions, which we're working our way through. And what members have got today is 4 actions based on this last goal. And they are mainly, I guess, around this area of isolation and loneliness. And I'll just, before I hand over to my colleagues, just preface this in terms of the public health impact of loneliness. There are, you know, there's really strong sort of long-term public health evidence that, really simply put, there are 3 major determinants of health. We often talk about a home, a job, and a friend. So those things underlying so much of the other things that we may more naturally go to, like smoking rates or alcohol, actually beneath that, a home, a job, and a friend. And I guess we're really talking about that last one today, the way people connect to other people, and the way that actually there's a substantial body of evidence about how that impacts health. Often quoted that loneliness is the equivalent of smoking 15 cigarettes per day, that sort of level of health harm and impact. So on that, I'm going to hand over to Penny and to Joe, who are going to talk through what I see as some really fabulous work happening across the city, which I think really speaks to this agenda item. So I'll hand over to you, Joe.
Evening, everybody. I'm assuming people have read the report because I know how studious you are, but I'll just pull out a few highlights that relate to the respective actions. And we also have a film to show you that reflects a gentleman that Penny has walked alongside in her local area coordination role. There's lots in this report that reflects there's a lot of activity taking place in the city, and there has been over a number of years to address loneliness and isolation and to build people's social connection, reflecting the power of relationships and relational centered practice, because we certainly recognize, as a number of practitioners do across the city, when you put relationships first, everything tends to work better. So the time we're afforded through the teams like social prescribing and local area coordination to build those trusted relationships with individuals, to support them to connect better with their communities, but to stay happy, healthy and safe at home, as opposed to coming into costly services, is something that we focus on. The first goal around supporting people to connect well focuses on the 2 teams of social prescribing and local area coordination, both introduced into the city way back in 2016 as strength-based, person-centered approaches with a growing evidence bank behind them. I think the profile of the 2 teams has been a total success story. They've connected with thousands of people, supporting them to lead good lives. And we have the film that I've mentioned that is Glyn's story, which will probably do it a lot better justice than what I could. So if we could play the film, and then Penny is going to tell you a little bit more about Glyn's story. Somebody that was introduced to us by a local councillor after a period of bereavement, some really challenging health issues and housing issues.
One of the local councillors got in touch with me and asked if I could visit Glyn. And we had basically what I would call the good life conversation. What would a better life look like for you? And there were a few issues came out of that. First and foremost, it was the fact that he was really isolated.
My mum had just died, benefits had stopped, and I wasn't getting out. I was just going into a shell, really.
So we started to look at some things that would improve his life.
Yeah, Penny invited me to the community meal. She come and picked me up and took me. I was having difficulty shopping, so she introduced me to Help at Hand, who come to your house and you take you shopping, or go shopping for you. You know, various. If I wanted any repairs doing, she introduced me to a handyman.
I was able to put him in touch with the Move Mates scheme so that he could get a walking buddy to help him get some exercise.
I started a walk around block. I did that 2 or 3 times. I thought, well, it's achievable. Then my move mate at the time said, do you fancy going further afield?
And that massively built his confidence and took him on to the next step, which was then to go to the health trainer, who then gave him support with giving up smoking and introduced him to the gym, where he now goes every Friday and has made massive strides forward.
It's like a domino effect. You do one thing, you know you can do another. You do 2 things, you do 3 things.
I think it's about teeing up those connections, really. Because he was growing in confidence, he was more in a position to take those connections forward. Where he was living, it just wasn't working for him, and there was a lot of antisocial behaviour.
He was kept awake with shouting and bawling, arguing, people fighting in the street. 10 o'clock at night, you got kids banging on windows and all that, you know, he was unbelievable.
So he put his name down on the housing register, and just before Christmas his new flat came up, and as soon as he saw it he knew that that was what he'd been looking for.
I feel a lot stronger in myself now. If my daughter comes now, if we're off to the gym, I just get up and go. Whereas before I used to say, I don't know. But now I'm up and away. It's like me being in control of my life again, where I was controlled by a letterbox. I was just waiting for a letter to come in from a letterbox, and then you acted on it. His quality of life has just massively improved. Everything's going my way, if you like, you know. You always pinch your backside, you know, and is it real? Yeah. It's just like getting your confidence back and being a person and being counted again, you know. Yeah.
Can you hear me now? Thank you. So the story of Glyn, it reflects the breadth that we're able to work with people. We're not looking at a list of deficits. We're looking at what does that person want for a better life, and we are using our huge range of contacts within the community and our breadth of knowledge as LACs to then introduce that person to various contact services. It could be voluntary groups, it could be a service like Handy Person was mentioned as well there. Move Mates played a big part, but we can introduce that person to groups, services, supports, contacts that can make a difference for them, and we're led by the person. But it's resulted in Glyn's case and in hundreds of other cases of people growing in confidence and then feeling that they can make further steps, further progress. And he has taken things further still since that video was made a couple of years ago, because within his independent living community, he now is reaching out to others. He quickly started to reach out to other residents who were isolated. He will be helping them with bits of shopping, just going, visiting for a chat, taking information, He's recently taken delivery of a load of Age UK leaflets so that he can make them aware of different services that are available. So he's a great illustration of how, as LACS, we've got that, we're rooted in the community, we've got that community knowledge, we're interested in the person, completely person-centered. Where do they want to go? What do they want to do? What does a better life look like? And that relationship personally with Glyn has now lasted for about 6 years. So, you know, we still talk from time to time. He knows he can phone me if he wants to. And so that that long-standing relationship is a good basis of trust for people to come back to us if they would like to, and just take further steps forward. Most of our introductions in Westfield Ward will be mainly from housing managers. They will be from adult social care. They will be from children's social care, social prescribers and mental health. And we just work across the whole breadth really of the community.
Keep going with the report, right? But obviously allow questions from the board. I think Glyn's story is a good example of somebody that was probably on the edge of social care. So as a result of that early intervention and prevention approach and strength-based practice, that's avoided probably the need for a social care assessment, but more importantly, has supported then Glyn to lead a good life and to connect with others and support them. There's another excellent link in the report to another person's story, a lady called Denise, who, after being diagnosed with a rare form of bone cancer, had a life-changing operation that unfortunately resulted in her having to have a leg amputated. That would affect anybody, but withdrew, was facing increasing levels of loneliness and isolation, dropping out of her particular community. And that's something that she was really passionate about. So she was introduced to her local area coordinator, had that sort of good life conversation. We supported Denise to get a functioning mobility scooter that's then enabled her to support her children to go back to school because they were dropping out of school and attendance was dropping. Denise, after us tapping into her sort of gifts and talents, we were naturally aware of what a spark plug she could be for that particular community where she lived. We've supported her to be trained up as one of the council's community health champions. She's now a qualified chair-based aerobics instructor and is leading those classes around the city. So again, seeing what's strong in somebody as opposed to what's wrong and having that sort of person-centered approach. Some of the couple of stories there from local area coordination, they could equally be stories from social prescribing. Yeah. But it's just, I would say, what a fantastic asset it is to have those two approaches in the city. The annex to the report that reflects the work of the social prescribing team has some amazing metrics in there that reflects the value of people connecting to their social prescribers. Just in the last year, it's the number of people that have been introduced in reflects 96% of those people that are introduced to a social prescriber have suggested that their levels of loneliness and isolation have decreased and they feel more connected there to their community. So again, some really fantastic metrics, very similar correlation to local area coordination there as well. And there's a really good story from the social prescribing team in the annex. I'll just move on to some of the other actions and highlight some of the initiatives that we've been involved in. So the second action 26 relates to the sort of asset-based community development approach in the city, the development of neighbourhood action plans and how we're trying to co-design community hubs with local people to help people to connect well and to address loneliness. In terms of our ward arrangements that we have within the city, led by ward councillors alongside local people, we currently have loneliness and isolation identified as a priority with 7 out of 17 of the 21 wards. and a number of the investment from the wards that goes into community action projects tends to focus on issues that will support people to connect well and overcome loneliness and isolation. Looking at an analysis of the funding, it's over 50% of the ward funding that goes into community projects that would help address this. We also have a growing network of community hubs that are supported to connect through our Good Place network. We've run 2 rounds of ward grant programs to support warm places in the city. We've just currently finished one of those, but back in the previous year, we actually had 28 projects funded to support warm place grants. And again, not only overcome issues of poverty, but also supporting people to connect well and overcome issues of loneliness and isolation. That's been enhanced by the development of the Family Hubs network in the city that again have identified the issue around connecting well. I mentioned the Community Health Champions programme. We currently have approaching 140 local people that have been recruited and trained up as community health champions. And again, there's an annex that reflects some case studies to the report. The Move Mates programme was mentioned, and you might have picked it up in the press, that the Move Mates charity has recently been awarded the King's Award for voluntary service. And just in the last year, there were 112 active pairings between a Move Mate walking buddy volunteer with somebody that might be struggling with loneliness, isolation, physical health, or challenges with their own mental health. And then again, there's a case study in there. I'm flying through this to allow some time for questions at the end. Action 27, again, relates to how we're trying to scale up the field of relational centred practice in the city, and again, reflect that in the work of our Age-Friendly York programme. Again, you're seeing the power of relationships through everything that we're doing across the teams that we've got referenced in the report. The Age-Friendly York programme, working with the York Older People's Assembly, has been fantastic to support loneliness and isolation. There's a number of initiatives that are highlighted in the report related to Age-Friendly York. That's me beeping, sorry. Working with the York Cares charity, a number of partners in the city, including ourselves, 2 Students' Union, York CVS, and others have been working with York Cares to learn from the Cares family national model of how you can address loneliness through intergenerational approaches, through bringing younger and older neighbours together, through social clubs in the city. So a number of social clubs have been run, and we now have regular monthly social clubs run at the Spurrier Centre and the York Community Furniture Store. And again, looking at local assets, one of the students from York St John has carried out a dissertation looking at the impact of social clubs in the city. Action 28 relates to trying to address gaps in provision and those that are at greatest risk of loneliness, and how we can address that through partnership action. We had a conference looking at challenges around loneliness in the city at the Guildhall earlier on in the year, working with the Curiosity Partnership, which is a network of universities that are looking at the power of research to inform priority settings around social care. So a fantastic event at the Guildhall where we looked at a number of the challenges we have around the sort of stubborn indicator on loneliness not shifting, and why that might be the case, given we're quite asset rich in the city, and we continue to focus, rightly so, on strength-based practice and person-centred approaches. So again, there's the opportunity to do further work with the Curiosity Partnership to try and understand this particular challenge a little bit more deliberately. And a couple more points and then I'll finish. Again, we've been working, as I mentioned before, with Age-Friendly York to look at some of these challenges, not least issues of transport that highlight the issues in particular for older people around accessing some of the fantastic assets we have if they're in the city centre. So it reflects the importance of ensuring that we have as many activities taking place in our local neighbourhoods and supporting people to get to those opportunities very well. And again, mentioning the York Older People's Assembly and the fantastic work they've done with the 50 plus festival, now in its 19th year. Again, really successful festival that highlights opportunities for our older citizens to connect with some of the fantastic activities that exist within our city. And I'll pause at that point to allow time for questions. We could have put a lot more in this report. It just reflects the amazing level of activity that takes place to try and support people to overcome issues of loneliness and isolation.
Thank you. Thank you very much for that. I really, really enjoy hearing the real life stories of the people's lives who are changed around local area coordination. I think it really brings it to life. And it always makes me think of when I used to work in recovery services, and we used to say to people, no one gets better sat at home on their own. So much of it is about community connections and building those relationships. And I think Glyn's story is particularly fantastic because he's now using his lived experience to support other people. So yeah, absolutely invaluable, and thank you for sharing that. Did anyone have any questions, comments? Councillor Webb?
Thanks, Chair. Thank you for the report and your work. It's clearly quite a valuable thing. It's something that's an important part of what we do in York. I suppose my questions are, I mean, firstly on the metrics, you said things are improving, but in reality, it seems a bit strange. I mean, it's been 25.70% year on year of percentage of adults who feel lonely often, always, or some of the time, and that's Annex 5. And it's been the same since 2019. It sort of feels there might be something slightly wrong with that metric if we're reading it every time. Right, Peter's nodding, that's a good sign. My other questions, my main questions though, is how are we actually measuring loneliness beyond saying to people, do you feel lonely anymore? And then if we've been like, you mentioned, Penny, that you've been working with Glyn and that he can still contact you a long time after. I suppose that's one way we can check if people are not falling back into that situation again of loneliness. But I mean, there's only so many of you to go around, Penny, so we can't do that for everybody you speak to. There has to be times that you would stop. And then my final question, while I've got the floor, is how do you see the ideal relationship with local councillors? Because I from what I glean from across the city, I think engagement and involvement with local councillors is varied, and I think it'd be great to get a feeling for what you potentially, this is one for Joe, see is how that should work and what you think best practice would look like.
So see if I can remember the three questions, and Peter might want to comment on the first one. I mean, the first metric around the loneliness indicator, I think it's captured annually, but the issue around that particular one is that the last information we had goes back to 2019. Yeah, so there's an issue there with the methodology around how we're actually capturing that particular metric. Yeah. How we then measure the extent to which somebody feels lonely reflects the relationships we have with them, but importantly, how we're trying to build up their own personal relationships and strengthening their family, friends, neighbourly networks, and the extent to which they can connect with local activities. So their circles of support. So often we might, and Penny might want to comment on this, work with an individual to sort of actually map out their circle of support and how we can strengthen that. That comes through in the shared agreements that we might develop with local people. And the last point about the relationship with members, with councillors, we see that as being integral. One of the things we would go through when we might recruit to a local area coordinator position is involve local people and councillors in that process. So local people are having a role in and voice in recruitment of a practitioner that's going to be working in their area, but also then maintaining that. So it would be very important for the local area coordinator to have a relationship with their local member, share stories, as, you know, share performance reports, but to also receive introductions from the local councillors. So we'd see that as being integral to the relationship that we're trying to foster at a place-based level.
Councillor Anthony. Oh, sorry, Peter, did you want to come in on that?
Thanks, Jeff. Thanks, Councillor Osman. Well, I think the point about data actually for me opens out the whole conversation for this board, actually. So the data's inadequate, absolutely. It was an Active Lives England survey that was carried out in 2019. The intention of the ONS was to do it every year, but then they didn't. And actually, we have pushed up back to Public Health England, OHID, to ask, you know, are they planning on releasing a new version of this? We planned the strategy based on what we thought were a good set of indicators. They mainly are, but that one isn't perfect. We actually have therefore included 2 other loneliness or isolation-based indicators from the social care framework, which are collected more recently, but they only cover those who receive social care or carers, which obviously is not the whole city. And for me, there is something about the conversation here about where we take this outcomes framework next over the next few years. So however recent, and it's not very recent, 2019, that is still a quarter of the adult population who are reporting feeling lonely some, most, or all of the time, which is just huge. So I guess my challenge to the board and to us, I think, is how we make sure that the brilliant practice that we've seen is done at a whole population level, because this is a massive issue and it can't just rely on the ability to be able to see every single one of these people reporting being lonely a large number of times. We'll never find that capacity. So how we do that. And then also the other challenge for me is about the bit of the population we're talking about. The reason the indicator said adults was because that is what the national indicator is. But I'm looking at the Campaign to End Loneliness website, and the risk factors that they're identifying for loneliness are 16 to 24 years old, most likely reporting loneliness, female, single or widowed, living with a limited mental health condition. Interesting. Previous conversations here this evening, are renting, have lower neighbourhood belonging or lower level social trust. So we actually have some risk factors for loneliness, which I think we could do with picking up in the next couple of years, maybe of the strategy, and saying, how do we make sure that the work we do, the next set of actions, reflects the brilliant practice of the work we've seen tonight, but moves it into the bits of the population we can have the most impact. Definitely picks up on loneliness affecting younger people, which I think is really important. And hopefully the indicators from national will follow, but unfortunately we can't do much more than we're given there from that. So I hope that helps with both the data question, but also where we take this next question, Chair.
I will just say that as LACS, we always try and introduce people to local resources. So we might encourage somebody to come and see us at a community centre when the community hub is happening. Or Acomb Library Cafe, from my point of view, is a fantastic place to meet people. It just connects them with the local community, helps them to feel more confident maybe about using a community resource and then becoming part of it. Some people end up volunteering at community centres as a result of our involvement.
Thank you. Councillor Rinsman.
Thank you, Chair. Got one for Penny, one for Joe. Penny, the one for you is, I know that the LACS had a really difficult time in the COVID lockdown. Do you feel that that effect has gone, or is it still there? And then I'll ask one for Joe.
Oh, that's a really good question. I think we're starting to see it move through now and starting to see people feeling more confident, but it did have a devastating effect on people. It really did. And we are currently working with people who perhaps were rehoused in the pandemic, and then had no contacts, no way of getting in touch with the local community, you know, putting down roots, making contacts. They couldn't do that. So that's the effects of that. We're still feeling that. Yeah.
Thank you. And the one for Joe, obviously I'm very aware that the relationship with local councillors is important, because I've had that all the way through. But do the LACS now cover the whole city? Is there one for each ward that you can make sure that each councillor knows who they are?
No, we don't cover all of the city, and we would have liked to, but obviously we've grown the team over the years, reflecting the resources that have been made available to us. So I think we probably cover, I think it's 12 of the 21 wards in the city at the moment, and that reflects the sort of need and demand, not least working with adult social care. So we've always tended to put local area coordinators in place, reflecting the interface with adult social care in particular, alongside wider issues of deprivation. We'd love to have local area coordination across the city, but we obviously know we're in currently really challenging budgetary positions, so and that's reflected in terms of the teams dispersed.
Just one final comment from me. It was interesting today to read that one of the government ministers, yours actually, is talking about earlier intervention. And that really is what we need to do and what we must do, not wait till things get serious. I'm hoping that if one minister thinks it, so do others.
Thank you, Councillor Winston. Sarah.
Thank you, Chair. Councillor Runciman's comment is a very neat segue into my comment and question. So for me, I was just going to take it slightly further than loneliness. And for me, this is about meeting needs as early as possible and as close to people as possible. So I know it is about loneliness, but it's kind of getting at the heart of our sort of health and care strategies to be able to do exactly that. So within that context, I've got possibly a question for Peter, which is about how do we at the Royal We see this connecting to our wider work around integrated prevention. So the wider, so we've mentioned LACS, we've then got social prescribing and health champions, but we've got other services across, for example, within general practice and other hub services and hub models that are also around prevention and targeting. So there's a question for me about how do you see this connecting to those services that are further downstream and then ultimately can end in the more specialist services. And we know that if we meet needs earlier, then we can prevent and support more sustainable and resilient specialist services. And then I do also have a question, I think, within the context of limited resources, which we are facing, both in terms of the cash, the funding, but also the staff as well, to be able to support people. So that's a question for Joe, which is, how do we know that the LACS are targeting the right people? And by that, I suppose I mean the people who've got the greatest capacity to benefit from LACS. Thank you.
Sounds like, yeah, me first and then my colleagues here. Great question, Sarah. I mean, I would say we have been doing quite a lot of work on what I guess you could call the prevention system in York. And I was mindful when we started that work that if we think of primary care, think of community care, perhaps social care as well, established systems with established workforces and national bodies that sit there and advocate for those systems and do a lot of work to make sure we're training the right people and we're skilling people up. There's something about prevention, possibly outside some of the classic public health bits like drugs and alcohol and sexual health, where the scaffolding around that bit of the sector is just, it's not quite there. And whilst it might not be there nationally, I think there is something about people who work in really preventative roles out in communities, tackling, absolutely, as you say, not necessarily the clinical, but often the social needs that underlie, feeling in a local area like they really join together and integrate, and we actually put the investment and support behind them. And I think LAC is a really great example of that. And one thing Joe didn't quite get onto within the report is the significant academic evidence and work that has gone on to try and demonstrate that across a cohort of people who may receive local area coordination services, the difference in terms of both the things you can measure that are self-reported in terms of well-being, standard ONS4 measures, that sort of thing, but then also what services don't see from a statutory point of view because a local area coordination approach has been taken is really quite significant at the population level. So I think that this report lays that out really well. I think that is a massive part of prevention. And as much as I think we scaffold prevention around as a system, we also challenge those working in prevention systems to demonstrate, just like every other area, the social care, the NHS, that they produce really good value for what they do. So that's, for me, your question about, are we making sure that things like local area coordination, social prescribers, the health trainers that sit within public health, are they absolutely meeting the most appropriate and amenable to change need? That's a real good challenge. And I think we probably need to move to that stage in our next bit of work around prevention. Hand back to Joe.
Yeah, the question about how do we know we're sort of working with the people that need the support the most. I think it's probably the same for both local area coordination and social prescribing, and any of the sort of partners that we work with, in terms of when we've gone through the setup of both teams and programs, we've been really careful to ensure that we develop the relationships with all the different parts of the system to ensure that we get the correct introductions, stroke referrals from, whether it be adult social care, children's social care, public health, you know, our different colleagues. One of the issues that we've sort of faced with local area coordination is the sort of primary reasons as to why people are introduced to the team have always been the same in terms of mental health, loneliness and housing. But then you've seen poverty and the cost of living rocket over the last 3 or 4 years, and that's come right the way to the top. That then reflects about how those issues all become more intertwined, and the issues then, as you'll know, Sarah, that are faced by people when they're struggling become ever more complex and challenging. I mean, Penny might want to comment as well. So I would say we are working with the right people. We're sometimes as good as the relationships that we have with the system to ensure that the right referrals come through, and that the referrals come through in a good way, so that they're good introductions. But it's that point around how we can look at the data that's available to us as well, in terms of population health management data, what local people know, what members might know, and how we're utilising that to inform how the teams are deployed effectively and work with the right people, because it is a finite resource, and as we know, demand is rising. We were just chatting before we came in about the level of introductions that Penny receives in Westfield is just rocketing. But that reflects the demand that is out there. That would be the same for all the teams.
Yeah, the referrals are coming from people like police teams, like neighbourhood enforcement teams, antisocial behaviour, that kind of thing. We hang out at food banks, so we're meeting people in poverty. I would say about 70% of our introductions at Westfield are as a result of poverty and disadvantage. So we make a point of ensuring that we're available to the people who are in the most need, and that we have good relationships with the professionals that might be wanting to introduce people to us.
Thank you. We're getting really pushed for time now, so if I just take 2 final comments from Alison and Sian, and then we'll move on. Thank you.
So I've completely changed what I was going to say based on that conversation. So I'm just thinking that not everyone who's lonely is receiving services or is in need of services. So the people who are probably the loneliest are people that are not being reached by anybody, and they don't need it. They're just lonely because they've been bereaved, or they're young. You know, they don't necessarily have to have some sort of intervention apart from being connected. So the big question is, how do we reach those people who are not on our radars? And I don't have an answer to that, but I think that's something we really need to look at. It's not just about people in services. We're talking about upstream prevention, aren't we, Peter? So before they get to services, how do we get to those people? And of course, I'm going to say that a vibrant and healthy voluntary community sector will help with that. So whether it's engaging people in volunteering, in lunch clubs, day centres, whatever it is, the services that have been provided by the VCS can help bring those people out. They don't need services, but they just need a bit of support to connect.
Thank you.
Yeah, I didn't mention it. Alison's right to point it out, but certainly in terms of the local area coordination team, the highest point of introduction is from people themselves, not from services. Okay. It's from people, their friends, their neighbours, from the community. Often it's as a result of somebody that might have benefited from working with a local area coordinator previously. I'm sure that would be the same for the social prescribing team, but it reflects the profile that the teams have in the city, that the highest point of introduction is from people. So self.
Sian.
Thanks, Chair. I think there's something for me as well about, are we using these roles and the services that are being provided to people to actually understand where there are wicked problems in our system that we can't resolve, but that we should be capturing the learning from, to think about how collectively around this table we solve some of these issues. So I know we're not officially a prevention services Health Watch, we're there to listen to people's experiences and feed them in. But increasingly, alongside our voluntary sector colleagues, we feel like we're ending up case holding individuals who have incredibly complex situations where no bit of the system actually wants to help them. And I know we've had long conversations as system partners about, we want to be able to be responsive to need when it presents itself. So how do we do that in a system that is strapped for cash, that actually struggles to afford the statutory requirements we need to provide? How do we be brave and bold and invest in these sorts of services that genuinely do meet those needs? And how do we then take the learning from those of the bits that aren't working in our system that need fixing to prioritise getting those right for people, so that they're not being held somewhere by somebody, but actually we're getting to the root of the problem and fixing it properly? Because I think I know for us post-pandemic, we are now seeing a number of individuals who have bounced all the way around the system, and there is no fixable problem, but there is something going on that needs addressing. So it's lucky for us that we sit alongside the social prescribers. We can take a lot of those situations to them for the bits where there is an answer. But there are some questions at the moment that we don't have an answer to. And I think collectively as a system, we need to understand those questions and find answers. So that would be my pitch, really. How do we use this better to inform what we're doing?
If I can just say, part of the LAC model is system change. It's about identifying what's not working, identifying what could be done better, feeding that back through to the system to bring about improvement.
Peter, did you want to come in on that?
Well, Chair, I was assuming that you were drawing it to close. I just wanted then to say that an action we could take away, thinking about our next couple of years of the strategy, and from what I'm hearing around the table, is that we probably want to focus our actions on precisely what Penny just said there about the system change behind social isolation, the upstream stuff around socialization and isolation and loneliness, and the potentially thinking about younger age cohorts as well. I mean, I'd throw that in actually, just based on the evidence. So if board members are happy with that, we can take that as an action for today into programming into the next couple of years of our strategy, the types of things we'd focus on. We can obviously have that conversation when we get here in January about the next couple of years, but we might put that as a proposal to the board.
Thank you. Go on, Councillor Webb.
Sorry, it's not on well, it is an event.
Whoops.
Sorry, I'll be quick. A slight amendment to that. I think I'd like to see in other parts of the country, in other parts of the world, if there's all this research, you know, what are the funding models anywhere and everywhere? Because we're hearing police are referring people in. This is something we're doing in the council. It's clearly benefiting health. And I just want to know what is out there, because we want to do this. If we're going to do this right, then we need to make sure that we're looking at how we can best support it. So yeah, I think because we've all talked about limited budgets, haven't we? So if we could add that in, that would be really helpful.
Thank you. Okay, thank you very much for that. Really useful and very informative. Thank you. So we're going to move on now to agenda item 7, which is the Health Protection Board Annual Assurance Report. I'd like to welcome Wendy Watson to the table to speak about this, who's going to be present it with Peter Roderick. You have 25 minutes for this item, and that includes presentation and discussion. Thank you.
Thanks, Chair. Well, I'll kick off on this again, and yeah, real pleasure to welcome Wendy and my team here to talk about this. When I started public health training, there was sort of a slight myth that went around in the public health community that we've moved on from infectious disease into chronic long-term conditions, and that the diseases of the past which are infective in some way were the diseases of the past. And I think, you know, the last few years has probably taught us that was a little bit of a mistake. And I think infectious disease and the way in which it affects human health, I think globally is now being seen as much more of a priority, and we haven't quite conquered. In fact, we've only ever managed to eradicate one single pathogen, which is smallpox. And so with that background, and with the background that we've all come out of a pandemic of a respiratory virus, but since then have seen, you know, threats to health in this country from diseases you'd never associate with this part of the world: Zika, dengue, yellow fever, West Nile virus, these types of pathogens which are being found in the country. When we think about infections that are resistant to antibiotics, which is potentially up there with climate change as the biggest public health challenge facing the world. When we think about what we've seen in measles rates, Mpox, and the current situation around a number of cases of that being found in the UK. What this report does is to give the board a little bit of an assurance on this really important bit of human health. And it's part of a mechanism of the way we draw together the work that happens around health protection in York, which, due to, in some ways, the fragmented nature of public health, sits across a number of different agencies. Hence why we draw a whole report together and present it to both this board, but also to the council's executive. As the Director of Public Health, I have all the statutory duties around protecting the health of the local population from both infectious disease and hazards harmful to health. But probably about 90% of the workforce actually sit elsewhere in different bits of the system, in the UK Health Security Agency predominantly, but also within environmental health within the council and within the NHS, particularly when it comes to screening for disease and immunising the population vaccination. So because of that, in order to make sure that I have assurance and that we all have assurance as a Health and Wellbeing Board, we draw together this annual report, and it brings into one place a lot of work that is happening. And essentially, we look to our partners to feed in all the information that you've got contained in the annex. I chair the Health Protection Board, which meets quarterly, and all the partners there contribute to this report. So a big thank you to a number of people who've sent in a lot of information and has been collated by Wendy, which again, a big thanks for doing that. I'll pick out a few key messages. Wendy will talk a little bit, I think, about vaccination screening, that sort of thing. I expect she'll pick up all the things I forget to mention as well, or correct the things that I get wrong. But there are a number of these new threats. Mpox is a really interesting one where we've seen so far 4 cases, all related to one particular travel import within London, but a significant and significantly dangerous new infectious agent, which could really take off around the world, and a whole host of action that takes place nationally, but locally, particularly in healthcare settings, about what happens if someone were to present with symptoms of what is currently a high consequence infectious disease, so an HSID. So there's an awful lot of work which goes on around Mpox, and that I think is indicative of a system that we have here in York, working with our UK Health Security Agency partners about responding to outbreaks. And in this last year, we've dealt with the response that we've needed for Mpox. We've dealt with a rising number of measles cases, of which we have had probable cases within York. We've dealt with a real wave of whooping cough, pertussis, particularly in younger folk, probably getting on for the sort of the 100-odd more cases in York over the last 12 months, so significant numbers there. We've dealt with a potential new influenza variant on our doorstep, which also had an impact in York, and a large amount of work which happened around that connected with York Hospital. So there's been a lot of action within this area over the last year, which the report talks a little bit about. The report goes on to other topics, so to swerve to a different area, sexual health. It covers some of the challenges that we have with pretty much every STI, every sexually transmitted infection rising in incidence over the last few years, and some really challenging decisions, being really honest, that we've had to take as a council, as the Commissioner of Sexual Health Services, through public consultation over the last 12 months to redesign your sexual health as a service, which is provided by York Hospital Trust but commissioned by the council, in order to match the resource we've got available with the needs of the population. And that again is outlined in the paper. The paper also talks about those hazards which are not infectious specifically, tells a really positive story that I'm really proud of around air quality and the work that we have done through now 4 different air quality action plans, which has reduced the number of management areas in York from a good number scattered about the city to now essentially just one central air quality management plan, and only one of the roads within that exceeds the WHO exceedance target of 40 micrograms per metre cubed. So there is some really good work on air quality that has happened through a large amount of electrification of vehicles, air quality alerts, work around the way traffic moves around the city, other sources of air pollution. Air quality now nationally is really moving on from outdoor air quality, still a hugely important issue, but thinking about indoor air quality and the effect on health that we previously really hadn't realised. And as air quality has improved in the UK, unfortunately, more and more research comes through all the time about how air quality is even more impactful for human health. You know, even after the last year, evidence around air quality and cerebrovascular diseases, so dementias and the like, really strong links that we had no idea about probably even 5 to 10 years ago. So some really important, good work around air quality, but a lot more still to do. There's stuff on the report around environmental health, land contamination, which I won't go into in detail, stuff around control of major accidents and hazards. So some really good work around migrant health, particularly thinking about some of our asylum seekers in York who have often arrived in the city with either incomplete vaccination records or they just haven't had the vaccinations that we generally expect for our population. And we've really seen some increase in uptake and coverage in those communities, which is really good to see, but still some real challenges there because of the transitory nature of migration. We are generally seeing most of our unvaccinated population probably in York coming through that bit of the population. So at this point, I'll hand over to Wendy to talk a little bit about vaccination screening, because we thought that board would probably also be interested in what's happening this winter vaccination programs, winter planning. It's obviously very cold, so it brings it to a mind, doesn't it? And it's a really important thing in terms of the healthcare system as well and resilience. So Wendy, I'll hand over to you if you want to raise any points on that or anything more.
I've got a cough, so if I start coughing, sorry, and can't speak very loudly. You'll see, I mean, I've written most of it in the report, but I'll specifically concentrate a little bit around screening immunisation. So for the screening, some of the programmes you'll notice have started extending the cohorts. Bowel screening, breast screening has done over the last few years. And I think what we're coming out of the effects of the pandemic from screening, unfortunately, a lot of the data we get is very old, right? We're getting 22, 23 data. And so that's what is published. But the message from the programmes and from the programme boards they have, which we work closely with NHS England, are that things are improving. There's one specifically, abdominal aorta aneurysm. I mentioned it in the programme. It looks dreadful, the data, but there was significant capacity issues. They had no capacity in the system and in the programme, and that's increased dramatically. So it kind of feels like it's okay and it's getting better. There's quite a lot of work with health inequalities in all programmes, working directly with the programmes, especially around bowel cancer screening, targeting men specifically, a lot of work with sporting venues, go racing. They're looking at darts and specifically men's sports, things where they can target the population. So with cervical screening, there's the data sometimes shows that it's the younger population, and we know that it's the first age that don't attend. So there's been quite a lot of work around that. But I think what's really interesting to know is sometimes the data is really wrong. And so everything I talk about in screening names, there are issues with data. But generally in York, the picture is that it's going quite well. Peter was talking about winter pressures, and we know that weather like this, like we've got at the moment, people who are susceptible to winter viruses will get poorly quite quickly. And obviously we're screening immunisations, immunisation is part of that. We do really well with flu generally as a local authority. And this year, the sort of good news story is that the young people, the school age flu is well in front of what it was at this point last year. They start on the 1st of September. They haven't always done that, but where we are from especially secondary school, we're miles ahead. We had a new vaccination provider who started last September, in September 23, called Vaccination UK, and we work really closely with them. We have fortnightly meetings. They're working really hard. They're really pleased with the uptake, working hard to get home educated children on board, because there's some issues with consent. We've worked really hard around consent in schools, and they're also doing a lot of MMR catch-ups as part of an opportunistic offer. The rest of the flu statistics up to last week, which are good. The good thing about statistics is in flu season, we get them every single week. And it's looking about the same as it was last year. We started the programme a little bit later for the over 65s and the under 65s at risk. It was a month later than usual, and we're nearly where we were at this point last year when we started a month behind. So that's the sort of screening immunisation bit. You will see in the report there's something about MMR2. We've always seemed to, our second dose of MMR is lower than the target of 95%. There's some significant work was done with the practices last year with data cleansing, and just from cleansing the data, a really onerous manual task going through data. The uptake went up by 12% without even giving a vaccination. So there are some issues with data, which the national team are aware of, and the project that we did in York was shared with the national team and very well received. And I think that's about it. Our winter planning it focuses a lot about comms, which is in line and follows the national UKSHA, the UK Health Security Agency plans, and we emulate that, and we've got a really good comms team who have been getting those messages out. I think that's all, Pete.
Thanks, Wendy. Before I have questions shared, just to say on then what we're seeing this winter, we had a hump of COVID September, really high levels. That is going down as of this last week. Our flu is starting to rise. We know that flu generally peaks just after New Year, so early January. I'm sure colleagues at the hospital are looking at that data regularly and thinking about bed capacity, etc. Really high RSV, respiratory syncytial virus at the moment. A new programme which has come on stream to vaccinate against that, super positive. However, this first year is unlikely to have a huge effect on population incidence. In future years it will do, and particularly for our youngest, which is where we're seeing the increase at the moment. That is a maternity delivered programme, so obviously those babies would need to be born first. So no, future years will see the impact of that maternity programme. Thanks, Chair. Hand over to questions.
Thank you, Wendy. Thank you, Peter. Does anyone have any questions? Councillor Webb?
Yeah, just comment first on school vaccinations. I mean, well done. I'm a school teacher. I see it in school. The speed at which you can get children in and out vaccinated is amazing to behold. My main question is about, you mentioned oral health in children and the issues faced by oral health in young people. And you know, this is not a new thing, but I suppose my question is from a public health point of view, you know, what are we predicting are the next stages of this? If you've got a 5-year-old with oral health problems now, or a 10-year-old with oral health problems now, what does that mean for that 10-year-old, that 15-year-old? And how do we, and potentially anyone else health-wise, maybe think about how do we look into the future and think what happens next? What are the predictions for those young people?
I'm happy to put that out with it. I mean, it's a really good question, and I guess one of the sad facts about our poor oral health, particularly in the UK, is that it's poorest and it's programmed in at that very early age. A recent Radio 4 program I was listening to on this, you know, was talking to a dentist who was talking about tooth extractions for a 9-month-old, so literally probably only 3 months of having a tooth, and it's being taken out for decay. So that is a sort of thing we see in communities, and we don't have good oral health, and we're not filling our mouths with really good products for oral health. We're filling our mouths with high sugar content products that lead very swiftly to decay. So we will see that track through, and we know oral health is a bit of a Cinderella part of public health. It's hugely linked to cardiovascular health. So actually your likelihood of having problems with your heart later in life is massively related to oral health due to a particular bacteria that circulates in the mouth that exacerbates certain symptoms. So there's things like that. And then just generally, it's just so wrapped up with poverty, so wrapped up with disadvantage. So I really, there's a good story in the paper about some local things, our expansion of supervised toothbrushing, flexible commissioning, where even though dentistry is in a difficult state in the city, coming either through social care, children's social care, or health visiting, children can get faster access if they are in those more vulnerable cohorts into dental treatment in York, which we didn't used to have. And that's come on stream in the last couple of years. But in general, we know that it's a big public health issue, and it will then play out into later life. It will play out into eating habits and dietary habits. And unfortunately, some of that is hardwired in.
Did someone, no? Did anyone else have Alison, you were next.
Thank you for spreading the joy today, Peter.
Mm.
It's lovely. So, I've just got a couple of comments about how the VCS voluntary sector can help with this, particularly on the vaccine programme. So we've just recently done some work commissioned by the ICB to reach the people that health can't reach around vaccine hesitancy. So we worked through 10 of our voluntary organisations, for example, the Travellers Trust, so trying to reach diverse communities to dispel myths and tell them about these are the facts around vaccines, so they could make informed choices about whether they took up the vaccine. So the message really is work through the voluntary sector as far as possible, because we have existing relationships with those people that you can't necessarily reach. And I think we did some proactive social prescribing around cervical screening as well. I don't know if you commissioned that, Peter. So it was some of our social prescribers in your old role, working with women, targeting women who weren't turning up for their screening for various reasons, and got to understand what those reasons were, which might be sexual abuse or anything which stopped them from going. And I don't know what the outcome of that was, but again, it's about putting in that support where it's needed to get to the bottom of what's going on.
Can I just come in there, because there's been quite a lot of work done in sexual health services about opportunistic screening for some of the reasons you've just said, when there's been sort of sexual abuse. So there's been quite a lot of work done around that in sexual health services as well. And I was at a recent meeting with some of the people who've done the vaccine hesitancy. It sounds like an excellent project, and they've done some stuff about Braille as well, about invitations. So I'm really, really keen to work with you, because in my previous role, we did a lot of work around that. So I think that's an excellent opportunity.
Sian, did you want to make a comment?
Yeah, just on the cervical screening issue, I know Healthwatch England have recently published the findings of their national survey and some qualitative interviews, and we were one of the Healthwatch that did a couple of those conversations with people about cervical screening and reasons for not taking it up. So if you haven't seen that report, please do. But again, there was quite an appetite from women around being able to do the cervical screening at home. And I think the technology exists. We're still waiting to see whether we're allowed to do it, but I think it would massively improve and deal with a lot of the issues that women have about why they don't want to do it in the first place. So I can't help but feel if it was anything else, we'd have already done it and given people that option. And I really hope that rolls out from a national level to give more women the chance to take their health into their own hands, so to speak.
Absolutely agree. That sounds really good. Okay, did anybody else want to come back in on that? Could I just ask a quick question, Wendy? It was about the MMR vaccine, when you said that we were below 95%, but not having the second vaccine, but then you'd looked at the data again. So are we below it or are we not? And if we are below it, is that below the herd immunity level?
95% is the World Health Organization target for herd immunity. The statistic, unfortunately, the way the statistics are reported, the data cleansing that happened won't be reflected in the statistics. So what is not from us specifically, but from the commissioners who work with general practice, it's been raised about correct coding of data. So just for information, if I don't know if you know, there's 2 MMR vaccines, MMR1 and MMR2. And this piece of work we did last year, we'd done something similar previously to that. And a lot of people were coded as having their MMR1 twice. But that won't reflect on the national statistics. So we don't know at the moment. So what we're doing is working with practice going forward to make sure that everything is coded correctly in the future. So it's a bit of a hiding to nothing in some respects.
Thank you.
Chair, if I could just clarify,
Yeah.
at point 19 then, I think I'm right in saying, Wendy, that data relates to a point in time measurement at age 5, doesn't it? So actually, if you have your second MMR after the point you're meant to, that's great to protect you, but actually it doesn't get counted in the data, which is exactly why that 12% won't show up in which is in some ways right clinically, but from a data and public health perspective, gives us a headache.
Capture of data and the MMR catch-up campaign it has been for everybody, but the cover data, it's called cover a vaccine evaluated rapidly. The national data source is done at 2 years and 5 years. So that's where it is on the count, that 5-year point, because it should be given at 3 years and 4 months. Although there are discussions to take the dose of MMR2 to a younger age. So that might all change at the data point that they collect the information.
Okay, thank you. Did anyone else have anything else? Martin?
Thank you. Nick, it is absolutely a wonderful report and really depressing at the same time. But I think what would be helpful, based on the previous discussions we've had about early help is really difficult to understand as to whether it works or not, and often it's a very long journey in terms of understanding whether that work is working. I do wonder whether the report in the future would really help from having data that goes back a bit further. So I suspect we are making significant progress in a number of areas, and I think that needs to be celebrated as much as being fairly concerned about some of the things that aren't where they need to be. I think it would just tell us whether actually some of the public health messaging, etc., really is working, but over a longer period of time.
Thank you. Thanks for that. Is that something that's a possibility, Peter?
Very much so, yeah. Really
Thank
great
you.
point. We'll take that on board. Yeah.
Okay, thank you. And thank you very much for coming, Wendy, and thank you, Peter, for that. So if we move now we're on to agenda item number 5 now. So that is the approach to working with people and communities in Humber and North Yorkshire, and the We Need to Talk engagement programme summary. Welcome, Anya Hayesbrook. I hope I've said that right. And Sarah Coltman-Lovell, you are also going to present this report.
Thank you.
Sorry, I should have said we're going to have 30 minutes for this report and presentation.
Thank you. So
Thank you.
Anya can introduce herself, but just while she's getting settled, just to sort of contextualise the report, if I may, Chair. So I suppose I just want to say we are very fortunate to have a very engaged, enthused and informed population in York. And I don't think all health and wellbeing boards or places necessarily do have that. So I think it's really important that we explore ways in which our communities can actively participate in both the work of place, which is about integration of general practice and community services, but also the work of the ICB with respect to core NHS service provision. So I was really happy to welcome one of our ICB executive members to come and talk about how we can connect our population. I really hope we see members of our community signing up to be part of that. The other reason for inviting Anya today was, you'll recall at the last meeting, we talked about the state of the NHS and some of the challenges and the issues that we're facing across the NHS, both in England but also locally. And I outlined that Humber and North Yorkshire had started to sort of recognise that there was a strong case for change within the NHS and more broadly as well, and that the NHS locally had taken proactive steps to start to engage with our population. So essentially, given those two reasons, it seemed absolutely timely to invite my colleague to come and talk a bit more about the work that the ICB is doing and also the early findings from that work. So I shall hand over to my colleague to take us through it. Thank you, Chair.
Thank you.
Thanks, Sarah. Thanks, Chair, and hello, members. Lovely to be here this afternoon. So I will take the report as read, but I will just pull out a few elements if that's okay. Then what I'd like to do is just to take us through some of the highlights, as Sarah said, of the We Need to Talk engagement that has very recently closed, and as Sarah touched on, very pertinent to the conversation that happened in this room at the last meeting. I will just say, building on what Sarah said, that the document, if you like, that you had in the pack, which is our approach to working with people and communities, isn't an NHS thing, as it were. This is something that has been developed very much working with wider system partners, so local authorities, VCSE in particular, to try and look at an approach to working with people and communities. Absolutely, I'm sure members will be completely cognizant of our duty to involve within the NHS, but what we have tried to do here is to develop a much broader approach. So I will just pull out some key elements of that, and as Sarah said, you know, I think it's particularly relevant for the Health and Wellbeing Board, because what we are trying to do is get much more of the local community voice heard and understood, and also a particular focus on some of our more underserved or underheard communities. So in terms of some of those priority areas, as I've just said, it's strengthening the voice of some of our more underrepresented groups and communities, to lead that new innovative way of system working, and we are on the journey there. It's not fully complete at all. Launch and build a more diverse public and partner membership, and develop that culture of participation, collaboration and improvement. And particularly some of the core deliverables that we're focused on are to launch and build a new public membership approach called Community Voices. So this is open to anybody, and there are different sort of scales of membership, as it were, that were set out in the accompanying document. But as Sarah touched on, you know, any member of the community, any contact that you have got is very, very welcome to join into this membership, and to make sure that their voice and the voice of their community is heard. Linked to that, we have a very successful, it was an NHS sort of pilot project, if you like, but it was particularly successfully delivered in the Hull area, which is Working Voices, and that's particularly around supporting employers to improve the health and well-being of their workers, obviously. So what's great about that is that it not only provides the support, information, guidance, etc. for employers, it again creates a community of practice where employers are sharing with each other what's working, what's not, and that's been really successful, as I say, particularly in the Hull area, but it is something that we want to broaden across the full ICB geography, and again would really value any help and input into extending that particularly into York. Our Insight Bank has recently launched, and I know some of you have been involved in this, and this is again trying to work more as a system to understand who's doing what in terms of insight and intelligence across the system. So we're not duplicating an activity, but that we are also building a repository that everybody can access into. You know, we want to know about what people think in York about access to dental services, as an example. It's a way of easily finding what already exists, what the gaps are, and how we can potentially build on that. As I say, and I don't apologise for saying it again, but we want to have that relentless approach in terms of engagement with our underrepresented community members and groups, and education and empowerment to ICB and wider system colleagues, because what we sometimes find is that, you know, we've talked, and you've talked very much at this Health and Wellbeing Board, we know the challenges, we know that many staff are really, really pressed to fulfil, you know, everything they want to, and so sometimes involvement and engagement can be seen as a bit of a nice to have rather than a core aspect, and so we want to really build more of that culture of putting the public, the patient first, and understanding more about how we all can play a role in that. But you've got the fuller document there, so I won't go over any more in relation to the fuller document. That is the working with people and communities. I'm very happy to answer any questions on that. But what I would like to do is just whip through quite quickly the highlights from the work that we have been doing again as a system. So a number of partners have been involved in this to better understand. And of course, again, we already know some things of what matters to the public, but particularly thinking about the fact that we know the NHS and our wider health and care system and the services provided need to change. So it was having that more honest conversation with the public to understand what their priorities were, to sense check some of the things that they've already told us, and to understand what really matters most. So the slides that you have in your pack and that are on screen are as of the 5th of November. So this was when we were midway through the engagement exercise. I have got the most recent figures, and I will say that most of the themes that I'll go through are broadly the same. There's just been more people that have said those things, if that makes sense. But in headline terms, and building on the slides that you can see here, we've actually had over 3,500 responses to the survey, which is a really good response rate for something like this. And approaching 200 of those, we can say, have definitely come from residents of York. Some people didn't want to tell us where they were from, so it's probably more than that, but we don't fully know. But there's definitely 200. And again, it's broadly the same as here. The majority were from members of public, but about a quarter were from NHS staff. And we've also, and more importantly, had over 1,000 in-person conversations. And those conversations were targeted again to some of those more underrepresented, I can never say it, underrepresented groups, and outreach into areas where members of the community that we don't usually hear from are doing their shopping, are having their coffees, are attending different events. So there's been over 1,000 of those in-person engagements. And of course, as you would imagine from that, it will take us more time to go through the more qualitative insight. But I have got some headlines in here that I'd just like to work through. And in your pack, you can see there the particular targeted events and outreach events that happened in York, and similar activity happened right across the geography. So in terms of what people are telling us in York, it hasn't changed in terms of the fuller picture. So you will see here that 100% of people from York have said that the NHS needs to change. And I will just say here that, and I'm sure you're all aware of this, in terms of the general public, they don't tend to understand how the health and care system is constructed. So they tend to think most things are within the auspices of the NHS. So they don't necessarily understand social care is delivered by the local authority or what community interest is. So that's why it's a broader sort of heading, and you'll see a lot that relates directly to NHS, but what they actually mean is the broader health and care system. And as you can see there, we actually played back to people what they've already told us in terms of a lot of the concerns that they have. But you can see there that what they have said are the key priorities are, and this won't be a surprise to you, but their concerns are that there are long waiting times to receive advice, treatment or care, that they believe health services are understaffed, and they believe that health services don't talk to each other, and that frustration of having to tell a story time and time again. And particularly I'll overlay here, you know, we did a group fairly recently of people receiving cancer treatment, and it was just so, you know, really upsetting to hear the stories when they're going through already a very traumatic experience, to hear that they keep having to tell their story over and over again, and it's just not connected. And that was something that we've heard over and over again in those in-person conversations. In terms of, sorry, I've got the clicker. In terms of the service areas that people think should be prioritised, they are in order: primary care, emergency care, mental health care. Of course, I know this is very prevalent to this agenda, social care and care for long-term health conditions. And then we asked people a series of questions about what they believe they could do to improve their own health and well-being and that of their family. We asked them what they were doing about it already and what are the barriers to it. This has actually slightly changed in terms of the fuller response. So increasing exercise and reducing anxiety and stress is still number one from York residents. But joint second is the improving mental health and improving diet. And then third is living in a supportive community, which I thought was interesting, and that has come out across other geographies as well. In terms of what is most important to the people of York, and I have to say here that the top three is the same in terms of all our geographies and when we've looked at top levels at different groups. So when we've looked at LGBT+, when we've looked at BAME, when we've looked at, again, deprivation, these three factors, there's sometimes a slight reordering, but they're consistent, and that is that people can get the care they need to look after their general health and well-being, that there are enough staff with the right skills and experience, and that care is centred around needs and that people are listened to. And it's interesting here, and I will say here, it doesn't mean that for particular groups some of these issues are not a priority issue, but certainly we always get a lot fed back to us around issues in terms of transport, affordability to access services, sometimes around infrastructure and buildings. These things are actually lower down the priority order in the general population, but I will stress again, that's not to say that with particular groups they are not a much bigger issue. And then finally, and I will just say here that I cannot do justice with this very brief summary to the very, very rich insight that has been provided through those in-person conversations. And at our board meeting last week, I thanked the public for their engagement, and I'll do the same here, because the honesty and some really powerful, very sensitive, very upsetting stories have been shared. And of course, then it's incumbent on us to actually do something to address the concerns that our public, our residents, our patients have got. But to summarise in terms of the headline themes, and again, I'm sure most of this won't be a surprise to you, most people feeling that NHS services are actually fantastic at a point of genuine crisis or emergency, but almost everything else leading up to that needs to improve, that it's very hard to get into the system, but once you're in the main, the staff and service is great, but again, there are some outliers to that. There are significant concerns around the variation in service, both within geographies, across geographies, and just different almost postcode lotteries as it's being described. And absolutely every single in-person conversation has referenced the incredible support of VCSE and community groups and services, and how the public feel as if they are undervalued and not a true part of, they don't say the system, but I'm paraphrasing, the system. Absolutely, again, the theme that services, people and systems don't connect and integrate, and a huge area of concern around communication, both at the more sort of macro level. So a lot of playback to us to say, you make it really difficult for us to navigate navigate. What on earth is the difference between an emergency department and an urgent treatment centre, as an example? But also, as you would imagine, a lot around patient level. And one of the most horrific stories that I heard in this engagement was a member of our deaf community that had been to an audiology clinic, and you're going to know where this is going from the outset. But they registered at reception, were told that there was a bit of a delay, so they sat waiting. An hour had gone by and they thought, well, this doesn't feel right. Went back to reception. A rather narky colleague said, well, we called you to a deaf person in an audiology clinic. And unfortunately, we hear many of those stories, and particularly again from again, our underserved communities. This won't come as a surprise, but again, the stories of the stress, anxiety, and wider impact on families, relationships, etc., of long waits for diagnosis and treatment, and a feeling of there not being parity between mental and physical health. And actually, quite a number of comments, a sense from members of the public that as a health system and service, we prioritise the elderly over children and young people. And again, I was struck by a comment from a York resident that who said, my 84-year-old mother waited 3 months for a hip replacement. Bingo, I'm happy with that. But why has my young daughter been waiting 2 years for speech and language therapy? And I don't think any of us really have a good answer for that one at the moment. And then finally, just a feeling from the public of their experience and what they see is significant levels of inefficiency and waste in our system. Everything from medication over prescribing, administration, which goes back somewhat to the communication point, and, you know, a big message of why do I need to make multiple appointments? Why can't I just have one appointment to address all of my issues? So that was a very quick run through, but I hope helpful, and very happy to take any questions. Sorry, what I should have said is this is now all feeding back in through what we call the System Leaders Forum, which some colleagues will be familiar with, which basically pulls together all the chief executives and senior leaders from across health and care in Humber and North Yorkshire, and it links into the Design for the Future work that Sarah has presented before. So this is absolutely all going into that idea of how our system needs to be designed for the future. And my final point is that all our findings are also going into the national work that you will understand is live at the moment. So it dovetails neatly in. So thank you. I'll stop there.
Thank you very much for that, Anya. Thank you. And thank you, Sarah. Would anybody like to ask any questions? Sarah?
It's just a comment really, which is probably a really obvious one, which is it's absolutely right that we make every effort to hear from everybody. But it's only meaningful if actually we then do something about what we hear. So I think in terms of making engagement count, probably what people most want to know is what are you going to do as a response to what you've heard from people about the things that they're most concerned about. And I think that's what I've heard from a lot of people recently, both at the York Old Persons Assembly and with the Carers Action Group, is that people say the same things over and over, but they don't see any kind of meaningful action or results. So I guess that challenge really is how, yes, we absolutely need to do more to listen and engage. And it's, you know, the efforts that we go to need to continue to improve collectively. But how can we really make sure that people want to engage because they can see that by doing so, they are actually directly having an impact on the things that are important to them.
Thank you.
Yeah, I think you're absolutely right. And of course, this is also coming very loudly and very clearly from central government as well. The reform message couldn't be louder, that we have to act on what the public are telling us. Now, of course, we we'll all appreciate this, but I will say, because to your point, it's stating the obvious, reform and acting on this does mean that there are going to be some difficult decisions, trade-offs, I think they've been called nationally. We had a very helpful engagement meeting, as an example, with some of our MP colleagues, who all again said we have to act on this, but equally I don't think anybody wants the change to happen in their particular patch, if that makes sense. And this is where we have to work as system leaders to make the right choices against what people are telling us, but more so take people with us. So we're explaining how we're acting on some of the things that they've said. I will just also say, and it wasn't covered in the slides, but there is also the opportunity to address some of the myths that may exist in parts of our community. So as an example, we asked a question around, if the NHS doesn't get any more funding, are there things we should consider not funding? And top of the list was gender reassignment and gender services. Now, I don't think any of us would think that that was remotely appropriate, that we would stop doing any of that, but it goes back to some of the prejudices that exist in parts of our community, and a belief sometimes that we're spending billions on some of these services. The same, I will share quite honestly, the number of conversations where it was a sense of, if you're white and British, you should be able to access NHS services. If you're not, you should be able to pay for it. These are some of the horrendous views that people hold, but we can't pretend that we haven't heard that. We have to play it back and take a stand, but also say why it's really important that we are providing care for everybody, but also quashing some of those myths that are saying, half the NHS budget is funding asylum seekers, or whatever the particular myth of the day is. I think we have to do that as well. But yes, absolutely agree with your point. And sorry, I should have said a bit of a trigger warning before I said those things. But some people feel as if they can say those things as well, which I think is also deeply concerning.
Thank you for that really honest feedback. Sian.
I'm going to start really annoyingly with a couple of minor quibbles. The first one is on the in-person engagement, you've got the Gallows Community Centre on there, but that's in Barrowcliff in Scarborough. It's not a York place. So, so maybe want to exclude that from the York figures going forward. And then on the slide about what's most important to people in York, I was just looking at the scale on that, and it goes up to 1,400. And if we've only had 200 responses from York, roughly, is that actually ICB wide rather than York specific? Yeah. So when we get the kind of final figures, if we could make sure that so very annoying, but what did strike me is, if we've got around about 3,000 responses and around about 200 of those are from York, plus some unknown, that's less than 10% of the responses across the 6 places from York. So there's a question mark for me about how we collectively work to drive up participation, engagement in the city. Now, I know there were some challenges around the timing of this, so I think we found out about it on the Thursday and it launched on the Monday, and we had a meeting with some of our voluntary sector partners saying, we'd really like you to get this out, and they all said, well, we've just sent our newsletter for the month and it'll have closed by the time our next newsletter goes out. So I know it's really difficult. I know things happen in the NHS when they happen, but there is something about, if we can plan these things in with a bit of a longer lead time, it gives us the opportunity to try and get more people involved. And I think there's a real challenge in York about, there are people that we speak to who are desperate to engage, who feel like they keep saying, talk to me, and then we're not making the most of those opportunities when they can actually feed in, which adds to that frustration and actually adds to that lack of understanding between what's going on at ICB level, what's going on at York Place level, and how people feed into some of that. So I think there's also, for me, a clear need. I know that you've identified 3 different levels of membership that would enable people to be engaged proactively by the ICB through some face-to-face meetings for some, through surveys and different. So What we've asked for is clear contact details for how people put themselves forward for that. And I think it would be really good if we could share those with the minutes from this meeting and have them on our kind of websites and things, that if you want to talk to the ICB, here's how you become part of their gang. Because I think that would be a really simple way to let people who are interested know here it is. I would echo Sarah's challenge about what you've presented reminds me very much of the work that we as a group of Health Watch did across the, it wasn't the ICS then, it was the STP, wasn't it? Sustainability and Transformation Partnership, in the 10-year plan work that we did for NHS England. So I would say most of this we have heard before. What's going to genuinely be different for people as a result of this? How do we change that? How do we make people feel like the NHS is moving in a direction that they would appreciate, value, and recognise as improving their care? And I absolutely applaud you for being honest and open about the challenges of that and what people's priorities may be. But I think we do need to be able to sort of start saying some positive things, because I think we've all been through enough. In terms of things haven't been particularly easy for anybody around this table, for anybody working in health and care. We want patients, people living in the city, to have a better experience. And I think it would be really good to think about what are we going to do with the results of this that start to address some of those issues and move people forward. I think we've done a lot of reports about some of the issues that have already come through here. We've talked earlier about access to GPs. We talked about our urgent care work. We've talked about making use of pharmacies more, and the pharmacy work we've done. We've done reports on mental health. We've done reports about neurodivergence and how that's landing in the city. I think there is a vast amount we know. I don't know if we need to know any more. I think what we need to do is actually act on some of the things we already know aren't working. And I hope we can do that together.
Thank you, Sharon. Would you like to come back?
Yeah,
Anya?
all absolutely. You know, great points. Well made, Sean. On the last point, and other colleagues might want to come in. I mean, I do think there is a real difference in terms of genuinely the system coming together and the impetus behind the design for the future. And you're right, and I said at the start, there's probably not a lot in here that you will find surprising, but what we wanted to do was just re-engage and to play back some of the things that people have told us before, so we can get a level of, you know, does this still matter and what matters most, so that we can make sure that, you know, system leaders and the teams working on those proposals are really capturing those. And we've also been really clear to this point in terms of that's what I'm looking for encouraging our colleagues to also see, and I applauded one of our NED colleagues on the board last week because they actually used the term customer service. I'd never heard anybody use customer service, and a lot of this is customer service, and he was making that point. It's not about new buildings or recruiting more doctors necessarily. It's a better customer service, and that's the bit that we're really pushing to say, where does that sit in a work stream? Because who's really looking after that? Because that's a focus that we need to have. And some of the things might be fairly, dare I say, low-hanging fruit, that actually, if we just focused on that, it would mean the world of difference to people. If we sort out that particular audiology clinic, that will make the world of difference to that group of patients. So I think there's something about also, you know, breaking it down into chunks, because we can't suddenly make the whole system brilliant, but we've got to do that. And very quickly, on your point, which is absolutely right, around that lead-in time. What we're also working with colleagues to do is to then start mapping this out, because there'll be a series of more in-depth. So I don't know, let's talk about maternity. We need to talk about maternity. We need to talk about mental health. And we want to be able to share that with, obviously, Health Watch and other partners well in advance. So we've almost got the plan for the year or 2 years in terms of this is how it all breaks down.
That would be very welcome. And I just wanted to say that did make me feel like a little bit like going and sitting in a corner crying when you talked about the deaf awareness issue in audiology. I mean, we did a report on that in 2014. And then we've had the Accessible Information Standard, and I really feel like we should be doing better on that.
Thank you, absolutely. I'll take one final comment from Councillor Runciman, please.
Yeah, I think it'd be quite a good wrap-up comment, really, but I want to say I've been to audiology a lot, and unsurprisingly, and I think there's just staff training needed. That's really simple. But what I think should happen is this should come back. And I hope that Anya and Sarah will bring back when they feel they're ready to show things have been happening and to tell Health and Wellbeing Board the progress is being made. Just that's following up what you said, Sean. We've got a load of information. Now, what are we going to do with it and what's going to change as a result? That's what we really need to know. Thank you.
Thank you very much. Okay. Thank you, Anya, very much for that.
No, thank you, and delighted to come back.
Absolutely. Thank you very much. Okay. So we move on now to agenda item 4, which is the chair's report, my report. I will just go through some themes really quickly on this, and then if anyone wants to ask any questions of me or anyone around the table, then we shall look at that. So the report is split mainly into 3 sections. So there's partnerships, children and young people, and public health. So I just thought I'd highlight briefly something on each section. So we have already discussed it briefly this week, but under the Ageing Well partnership was to look at the Over 50s festival that took place September, the week between September and October. And it was the 19th year of this, and it was just really incredible to see the programme for that, to see the list of activities for that. I think there were over 120 activities, which was absolutely amazing. And if we're looking at supporting people around loneliness, isolation, I was really hopeful that people would attend some of those things and become involved in their community, or there'd be something to inspire them. Under the children and young people section, I just wanted to highlight the amazing news of the Send Hub that's been approved for children with special educational needs and disabilities and their family. It'll be run by professionals from several services, including health and social care, based at Clifton Family Hub. And I think what's really special about it is that it supports people in navigating a really tricky system, from people who've been through that system and people who have navigated at time what can be quite complicated, and has been co-produced with parents who have lived experience in that area. And then on the public health section, just looking at the tobacco and vape bill, which is hopefully going to be around soon, about the supply of tobacco and vapes, including the provision. So anyone born after the 1st of January 2009 will never be able to buy tobacco. And I think it is one of the longest, well, it's going to be one of the most impactful public health campaigns that we've had for many years, and will hopefully help us raise the healthiest generation of children in our history and save thousands of lives and help support putting money back into the NHS. We've still got tobacco responsible for 160 cancer cases a day, and it'll go further to reduce smoking and vaping in outdoor areas around schools, playgrounds, and ban on advertising. It still needs to be voted through, but it does really show a commitment to prevention, how we were speaking about before, looking at the real root causes and getting things sorted before they become really problematic. And just, there is one more, I just wanted to highlight the supplementary statement that everyone should have for the pharmaceutical needs assessment, which is referenced at paragraph 38 in the report. So we've updated it. And this was following the scrutiny committee did receive a report on pharmacy provision in York and the pharmaceutical needs assessment, but there was a gap identifying provision in Clifton following a closure of the chemist that was in Clifton. Following the tender process, all 3 applications to the pharmacy were declined. So we've now submitted an enhanced supplementary statement saying that there is still a gap for pharmacy provision in Clifton, to support the appeal process for anyone who wishes to apply for that. In this new statement, we've said there's a need for pharmacy provision, and there is a gap in needle exchange, supervised consumption services that were all provided at this pharmacy, and it also highlights that Clifton is an area of relative disadvantage and people need pharmacy services in easy reach to be able to travel to them. And as we move to more integrated community services, pharmacies are so essential to people who live in these communities and just provide value, a really valuable function for people as we're using them for more and more stuff. So that is the pharmacy needs assessment and a quick update of my report. Does anyone want to ask anything? Oh, Sarah, sorry.
Forgive me, Chair, it's not a question, it's a comment, if that's okay, if that's allowed. So I just wanted to make a comment with regards to the supplementary statement around the pharmaceutical needs assessment, and just to reassure the board, of course, I am a member of the ICB, so whilst I may not be responsible directly for commissioning community pharmacy services, I have made representations to my colleagues who are responsible for community pharmacy services. Myself and Peter Roderick, Director of Public Health, have been working closely to ensure that the right information gets to the right people. And just to say that we are still in the appeal process, so that the process hasn't concluded as yet. So we got that information at the right time, Chair.
Okay, brilliant. Thank you very much, Sarah. Anybody else? No? Okay. Well, thank you very much. That brings us to a close. Thank you.